Through this video, I will be discussing Q exposure therapy with a focus on addiction. First, let's discuss the role of Pavlovian conditioning. As we know from homeostasis, we undergo specific reflexive responses regarding unconditioned stimuli triggering unconditioned responses. Although if we incorporate Pavlovian conditioning, a conditioned stimulus that is present prior to every exposure of the unconditioned stimulus can create a conditioned compensatory response before the unconditioned stimulus even appears. This is because the compensatory conditioned response occurs prior to the unconditioned stimulus. So, what is Q reactivity and how does it play into this? Q reactivity is a type of learned response that is often observed in individuals who deal with drug addiction. Drug-related stimuli or drug cues are seen to lead to drug craving and various physiological responses, creating cue-specific reactions to drug-related stimuli. These stimuli can include, but are not limited to, drug paraphernalia, drug-neutral cues, or the sights and sounds of the environment in which you took the drug. Individuals with drug addiction are highly reactive to environmental cues associated with drug use. These individuals can exhibit increases in craving, heart rate, and subjective withdrawal symptoms. Familiar pre-drug cues create conditioned compensatory responses that would usually be used to counteract the drug itself. Routine largely influences the creation of conditioned stimuli, such as the sight of the drug or seeing individuals around you take it. By avoiding cues associated with prior drug use, individuals would have a larger likelihood of remaining abstinent from the particular drug. So why Q exposure therapy? Let's first discuss what Q exposure therapy is. Q exposure therapy aims to extinguish individuals' conditioned responses. For drug use, Q exposure therapy can extinguish a person's conditioned responses to drug-paired cues, leading them to experience less cravings and a lesser likelihood to relapse. With repeated exposure to the stimulus without it being paired with the actual drug, the strength of responses gradually extinguish. If an addict faced a drug-related cue, they are very vulnerable to relapse, although with the help of Q exposure therapy, individuals can develop a sense of individual control over their addictions. This can occur when there is a gradual exposure to pre-drug cues that no longer have an association with taking the drug due to the lack of administration of the actual drug itself. So now I'd like to discuss a bit of evidence for and against exposure therapy. In a study by Franken, 16 opiate-dependent patients were assessed on their severity of their addiction. They participated in an outpatient resocialization phase, which included Q exposure therapy following inpatient treatment and detoxification. Stimuli, which included videos, slides, drug use material, and exposure to drug-related cues were presented. There were 4 different cues with 2 slides and 2 videos, each presented for 5 minutes. Neutral cues included slides of landscapes and a film or some type of scenery, while the drug-related cues consisted of slides of drug users who were using heroin and a video of it. Through this, the researchers aimed to look at Q reactivity, including feelings of depression, anger, tension, craving, and other symptoms following Q exposure therapy. Prior to Q exposure therapy, Q reactivity was very much present for patients after 12 months of intensive treatment. When individuals were exposed to drug-related stimuli, there was an increase in cravings and negative feelings. With the addition of Q exposure therapy, individuals showed a decrease in the amount of cravings, negative feelings, and physical symptoms that they had towards the drug, which lasted for 6 weeks after the Q exposure therapy trial. Q exposure therapy was seen to reduce self-reported cravings in individuals who had undergone long-term inpatient treatment. There is still a lack of evidence surrounding Q exposure therapy to prevent relapse for detoxified drug-dependent individuals and a lack of models describing Q reactivity and craving. More knowledge examples of drug-related stimuli could also be beneficial conducting Q exposure therapy. In another study, Marison and Franken looked at 127 abstinent heroin-dependent Dutch inpatients. The researchers wanted to look at Q exposure therapy and believed that it would lead to a decrease in Q reactivity and lower rates of relapse and treatment dropout. There was a control group and a group of individuals who received Q exposure therapy. The group that received this Q exposure therapy treatment was exposed to 9 one-hour sessions of drug-related stimuli with response prevention. Results showed that the researchers' hypothesis was actually the opposite of what they observed. Analysis of the Q exposure therapy group saw a reduction in physiological reactivity, but not self-reported cravings and mood. This study proposes a few factors that could be evidence against the use of Q exposure therapy. For example, this study showed that Q exposure therapy may only have partial effects on Q reactivity. The increase in self-efficacy that the CET group could have shown does not necessarily explain the differences in dropout or relapse rates. Another possibility is that the placebo psychotherapy group could have actually been effective. Q exposure therapy could also be ineffective if individuals are encouraged to expose themselves to detrimental drug cues. It could also be very time dependent and could be detrimental without effective coping skills and training. Q exposure therapy has been widely recognized to be able to reduce Q reactivity and to treat addictive behaviors. As I discussed before, Q exposure therapy has the potential to extinguish a person's conditioned responses to drug-paired cues, leading them to experience less cravings, less drug-seeking behavior, and a lesser likelihood to relapse. The goal is to extinguish these learned responses to drug-related cues through non-reinforced exposure. It can be beneficial to look at animal learning models to analyze how Q exposure treatment for addiction came about. It has been seen that current CET treatments fail to acknowledge some key findings when extinguishing learned behavior in humans. Conklin and Tiffany aim to look at Q exposure for addiction treatment and its effectiveness while looking at research to determine more effective ways to administer this treatment. We can analyze the promises and limitations of Q exposure therapy by looking at renewal, spontaneous recovery, and reinstatement. First, let's look at renewal. The context where conditioning and extinction occur plays a significant role in analyzing how one will respond when re-exposed to cues that have become extinguished. The situations and environment that an individual is in could largely affect their ability to extinguish a prior learned response. The context where the cue was associated and where it was extinguished makes a big difference. For example, let's say that an individual is an avid cocaine user at home. If that individual received Q exposure therapy in a hospital or doctor's office, they might go home and relapse because the conditioned behavior returned when there is a change in environment or context following extinction. A possible improvement to reduce renewal could be to extinguish conditioned responses in a variety of contexts in order to make extinction more generalizable. Another explanation for renewal effect to occur is if an individual fails to remember what they extinguished prior. One might not have the memory that extinction even occurred, leading them to relapse. To minimize this, a researcher may introduce a novel drug cue and pair it with extinction in the original conditioning context. Next, let's look at spontaneous recovery. It has been seen that extinguished responses can come back when the drug-related conditioned stimuli is presented after some time following extinction training. The passage of time has the potential to influence an individual to use the drug again in the absence of Q exposure therapy trials. Let's say that an individual received Q exposure therapy for smoking cigarettes, but only received the treatment once a month. These individuals may relapse due to the time that extinction training and Q exposure therapy takes place. The article states that in current Q exposure therapy practices, extinction has failed because many studies provide many short Q exposures in one session with the exposure of a novel Q. Full extinction may be more effective if there are multiple exposures or longer intertrial intervals between exposure and various presentations of different cues. Lastly, let's discuss reinstatement. Reinstatement occurs when an extinguished conditioned stimulus comes back as a consequence of exposure to an unconditioned stimulus following extinction. It is also largely influenced by the context or environment that an individual is in, similar to renewal. When an extinguished conditioned stimulus is presented alone in a particular context, conditioned responses can occur as they did prior to extinction. For drug users, it is common for them to be exposed to drugs such as painkillers, which can reinstate past responses to extinguished cues. By allowing for increased exposure in the context alone after the re-exposure to the unconditioned stimulus in that context, individuals pose less of a threat to reinstate cues in that environment. Q exposure theory can vary across all studies, including the range of sessions, length of treatment sessions, amount of time dedicated to Q exposure specifically, and the number of cues presented. Further research of the effectiveness of Q exposure therapy is still very much necessary. Overall, stated in this article, current practices of Q exposure therapy have not shown to be quite effective, at least for human subjects. Humans may take drugs in a variety of contexts and follow a variety of cues. Researchers also take on different methods to go about Q exposure therapy, leading to the need to standardize and revise some key aspects of Q exposure treatment.